So I will go ahead and talk to you about, so I sent a link in the chat, but I don't know that it goes to everyone, or if the organizers can send it out. But you can actually follow the article with me, or the guideline. It's available online. If you just type in clinical practice guideline tinnitus, you'll find it. And it could be a good reference for you as you move forward, if you decide to work with tinnitus patients. So what we're looking at, so let me kind of make it, to make it easy to follow, what I decided to do was we'll use 3 different patients. And let's say these are patients that are coming to you with tinnitus. What do you do, right? So in order to apply the guidelines, I think is the best way to do it is to actually have a good clinical example, right? So we have Mr. N, Mr. B, and Mr. T, and there's a reason why they have those letters. It's not random, but they're all males, the same age range, jobs, they're professionals in their job, they're doing well, they all have tinnitus, okay? Now, when we look at the main information that we get from them, you'll see on the screen, they all say they have high-pitched tone of tinnitus, at least 1 year or more, depending on the person. And then the last 2, the ones that are in quotations, means the patient actually said this. So they're saying that the tinnitus sounds like it's in their head. Mr. T said it was more to the left side, so he was able to localize it. And they believe that their hearing is within normal, but there was no actual hearing test done, okay? So generally, just looking at it, it almost looks like they're the same, with a minor difference. And now that we think about it, the reason why they were referred is for tinnitus. What do I do next? So let's look at the guidelines. If you were able to open the guideline, the document, these are the 13 statements that are mentioned in table 5. So history and physical exam, prompt or routine audiologic exam, imaging studies, bothersome tinnitus versus persistent, education and counseling, hearing aid evaluation, sound therapy, CBT, medical therapy, dietary supplements, acupuncture, and transcranial magnetic stimulation. Now, just because they're in the guideline doesn't mean that they are recommending you to do them. They're actually going to tell you for some of them, they are recommending against them, okay? So keep these 13 in mind, and looking at these, what else do we need to ask our 3 patients that we don't know? So if we look at bothersome and persistent tinnitus, I don't know if you're aware of the definition. So let's go through again. You'll find this in table 1, what it means for tinnitus to be primary versus secondary, recent versus persistent, and bothersome versus non-bothersome. So primary, there's no real, it's an unknown cause. It could and could not be related to hearing loss. Whereas secondary, it's due to an underlying cause. So let's say somebody that has Meniere's disease will have also tinnitus, or people that have, let's say, some type of tumor that's causing the tinnitus, that would be considered secondary. If you have any questions, let me know. I don't know if I get the questions or they go to the panelists, but however, even if you get the questions later, I'll try my best to answer them. So persistent versus bothersome, 6 months, less or more. Persistent versus recent onset, less or more than 6 months. And then bothersome versus non-bothersome, obviously if the patient is acknowledging it and it's concerning them or not. The ones that are bolded are typically the ones that these kind of guidelines will help you with. The main focus is usually for patients that have primary tinnitus, persistent, and it's bothersome. These are the ones that we really need to focus on. So if we go back to our patients, given that information, let's go back to, now we have to ask them if it's bothersome or not. And you can see that only Mr. B said it's bothersome. That's why he's Mr. B. It's bothersome, just so you can follow me as we go. Mr. N said it was non-bothersome. And Mr. T also said it was non-bothersome. So the only difference between N and T is that he says it's more towards the left side. Okay, so what do I do next? What do I do with this information that I have? Let's go to a hearing test. Typically, and you'll see in your recommendations in the guideline, it says, let me show you here where it was talking about prompt versus routine audiologic exam. If you actually go in and read what they're talking about, they actually recommend a routine audiologic exam, but not like a strong recommendation. But given the situation specifically, let's say for Saudi Arabia, typically the patient's going to come in for a hearing test. So you are probably going to do a hearing test. Now look at our results for these three patients. Mr. B and Mr. N, both mild, high frequency losses. Word recognition is excellent. Now, when we go to Mr. T, his hearing loss is almost exactly the same, just a little bit more severe. So it goes down to a moderate level on the left side, but look at the word recognition, 96% versus 72%. So the reason I'm mentioning this is because if we say we were going to do a comprehensive audiological examination, if you're only doing air and bone conduction testing, that is not a comprehensive exam. You have to do your speech testing. You have to do your admittance testing. So TIMS, reflexes definitely have to be included. Otherwise, we do not consider it a comprehensive exam. So let's say I did not do word recognition. I could say fairly that maybe it's just a bilateral hearing loss. Maybe it's test retest. It might be both mild or whatever. But when I do word recognition, now it's a red flag. There's more than 20% difference between the right and the left side. I am concerned now about Mr. T. Okay, so where do I go from here? As we move forward, Mr. N, for example, question mark on what you should do. He said it's not bothersome. He doesn't have a significant hearing loss. He's not concerned about his hearing. This is considered primary tinnitus for the most part. I probably won't do much with him. But Mr. T, for example, and we're going to go to the right side of the screen, because we have a red flag, we have an asymmetrical loss, not just air and bone, because it's not just air conduction. We have to look at speech testing. So keep that in mind. We refer him to get his history and physical, medical radiological investigations, etc., and he has a left vestibular schwannoma. So if we did not do the speech testing, you would have missed that asymmetry, and you would have missed that chance of diagnosing this patient. And this is, now we know for him, it is secondary tinnitus. So there is an underlying cause, right? Then I'm putting a question mark on tinnitus assessment and management for him, because then it's really going to depend on where he's at after they do any type of medical investigation, if he wants to move forward with his tinnitus assessment and management. And again, I'm starring it because technically we really have not done a full tinnitus assessment or management yet. All we did was a hearing test and we asked a few questions. That's kind of halfway through it. So Mr. T, it's really going to depend. The main person that we're probably going to be working with is Mr. B, because he said it was bothersome. No other issues are going on, no neurological, nothing that's showing up, because you'll also see in your guidelines that it's saying, you know, if they're showing an asymmetrical loss or they're showing neurological symptoms, that is a red flag. But Mr. T didn't show that. That doesn't mean that he doesn't have a vestibular schwannoma. We have to keep in mind that it's not always like what we read in the book. You know, the books, you know, we read it and it tells us 1, 2, 3, but they're not all going to show up at the same time. They're not going to show up at with the same degree, especially with vestibular symptoms, because we are taught usually that you know, if a person has a schwannoma, they're going to show also dizziness or imbalance. But remember, these are tumors that are slowly growing tumors. So the system has a chance to compensate. You know, they're not going to come immediately with vestibular or balance issues until they're like way ahead, and, you know, the tumor's big, you know, they're at a different stage, but initially they're not going to show up like that. So remember, just because they came in saying that they have tinnitus, it might not be the main issue. Okay, so that's Mr. T. Now we're going to deal with Mr. B. So now I have a patient, I know it's primary tinnitus, I know it's persistent, he said he's had it for a few years, and there's no other underlying cause. So if we go back to, well, I kind of mentioned this for Mr. T. So if I go back to Mr. T, we did the ones that are bolded, if you look at them, imaging studies is recommended for him because he has an asymmetrical loss. If you are dealing with somebody like Mr. B, then the guideline is going to tell you they strongly recommend against imaging. So we're not supposed to be referring every single patient that has tinnitus for an MRI. It's just a waste of resources, money, it doesn't make sense. But education and counseling, I'm underlying it because it's very important. Mr. T has to understand that, yes, this is what he has, but that, maybe tinnitus management is not a thing right now, but he has to understand that maybe if the tumor gets bigger, if his tinnitus becomes worse, then yes, he can come back, and then we can talk about assessment and management of tinnitus specifically. So keep that in mind. Education is key. The patients have to understand that they can always come back and that things might change. Now, if we go to Mr. B, you'll see that I crossed off the ones that, according to the guideline, they're telling you they're recommending against, okay? So history and physical, already done. We did an audiologic exam. We know it's bothersome. We know it's persistent. Now we have to educate and counsel, but what did it, and we hear that a lot. The question is, what do I talk to the patient about? Do I do a hearing aid evaluation? It is recommended according to the guideline, but the question is, does he have a hearing loss that's worth using a hearing aid for? Is it, again, a waste of money and resources for him to buy a hearing aid if he doesn't need it? Remember, he said that he's not concerned about his hearing. So that's why I put a question mark there. It might be something that you don't discuss with him. But again, when you go to education and counseling, you're going to say, but if your hearing does get worse and you are concerned about it, then it could be, you could get two benefits out of it. It could help you with your tinnitus, but also with the hearing loss itself. And this is where it's clinical judgment, and the patient has to make the decision as well. You really have to include the patient in decision making. If they're not ready for a hearing aid, then they're not ready, but you have other options. But they have to understand the benefits of it. Sound therapy as well, it could be kind of included in under hearing aid evaluation. So they could either use the maskers within a hearing aid, or they can use sound therapy separately. And I'll get into that in the slides coming up. Cognitive behavioral therapy is a really good one. When we talk about the ones that are crossed off, again, the recommendation is against. I'm not going to go into too much detail about why. You'll read it. It's very detailed in the guideline. And then acupuncture, it just says there's no recommendation at this point. Given this article was from 2014, we might be getting a new guideline with different information. So keep yourself updated when it comes to that. So if I go to questioning him about his bothersome tinnitus, right? So I'm going to go through my list here of what I need to talk to him about. How do I know how bothersome it is to the patient? If he just says, yes, it bothers me, that's not, it's not enough. You have to ask more questions. How bothersome is it? Because we're looking at the perception, but also the reaction to the tinnitus. That's what's going to show you how bothersome it is or not. You have to ask questions about quality of life. So is it bothersome because now it's affecting your sleep, your concentration, work, you're unable to go to your meetings or attend them because you're struggling? This is what you have to ask. You can't just say, is it bothersome or not? Everybody's perception of bothered is different. If you tell me, if I say it's bothering me and you tell me from 1 to 10, I'll say it's 1. I'm managing. I just said it was bothersome, but then somebody else will say, no, I feel like it's a 12. And now I'm thinking about suicide, and there's a very small percentage, but it could be very extreme for some of them. So you have to not just ask the broad question, but ask the detailed question, go into detail. And just by asking the patients, it definitely helps in motivation, because they feel like you're understanding them, you're trying to understand their problem. And it does go a long way. So if you have objective measures, questionnaires, surveys, use them. And I'm going to say use them again and again, because, and unfortunately right now, I don't know that we have any of these standardized tests or questionnaires standardized in Arabic. But so I'm not sure if anybody, where everybody is from that's attending, but yeah, if you have it available and it's standardized, excellent. Even if it's not standardized, I mean, you can say informally translated, use something, some type of measurement, because it helps in monitoring and in motivation. If you end up doing some type of cognitive behavioral therapy, sound therapy, you can ask the patient to fill out the questionnaire again a few weeks later, and even a little bit of a change is enough to give the patient some motivation to move forward. it also gives the clinician motivation, right? Because tinnitus is one of the hard ones. You struggle with it trying to get the patient to improve, and you don't see big difference. But if you have some type of objective measure, it's motivation for both of you. And it's things to look at, because depending on the questionnaire you use as well, some of them focus on psychological issues, some of them focus on quality of life. So you know what to target when you're counseling the patient as well. So it will help you, because you're not going to talk about sleep. If sleep is not a concern for this patient, it means nothing to him or her, right? So the questionnaire will guide you on where to focus your counseling, if that makes sense. Now we go to education and counseling. Okay, I cannot stress this enough. Anybody that knows me in clinic knows that I might spend most of my time doing education and counseling versus the actual assessment. I mean, yes, we'll do the complete assessment, yeah, but the main focus is education and counseling. It is, so regardless, tinnitus or other, whatever, hearing loss or whatever it is, but tinnitus specifically, it is very important. The patient has to understand what it is, how common it is, and we all know that they're probably going to forget some of the information, so always provide written information. Just by telling the patient that you are not alone can make a world of a difference. So even if it's just asking them by using a number scale, on a scale of 1 to 10, how bad is your tinnitus, or how frustrated do you feel? And they say it's 10. Just by saying you're not alone, there are training therapies, there are options, etc. They can immediately say, okay, I'm now down to an 8 because I feel a little bit better knowing that I'm not the only person, and I know that there might be something that can help me. So they have to understand that. And knowing that they're not alone, you can also mention, when it comes to education and counseling, having group therapy, because I can talk about tinnitus as much as I want, but the best information that I have when it comes from actual experience, I will use what other patients have told me and what they've experienced and try to help other patients, you know, because everybody can open a book or a website and find anything, but to talk to an actual person that had it is definitely a plus. So, and I've seen it. I've seen, you know, when you do group therapy, you'll see how the patients connect together, because they might hesitate to say something because they feel like it doesn't make sense. But when they hear someone else say it, or they talk amongst themselves, it makes a big difference. And that in itself can improve quality of life, improve their perception, their reaction to it. And like I said, it can be instant sometimes. Like just by saying those few things can make a big difference. So really spend the time on education and counseling. So if you're saying a patient came in for tinnitus, and I did a tinnitus assessment, if you spent just 15 minutes, I wouldn't consider that an assessment, right? If you're not spending at least 30 minutes with a patient and purely just discussing tinnitus, what it is, what options are available, giving them a questionnaire, all of that, then it's not enough. So keep that in mind. Dedicate specific time to discuss that. Regardless of what options you decide to work with moving forward, just that part can make a big difference. You're building the trust, you're building that relationship with your patient, and they'll now be patient with you and move forward in choosing and trying to find out the best option for them. And I mean the best option, I'll tell you why as we move forward, okay? So sound therapy, and again, we're talking about Mr. B as like an ideal example, but so hearing aids, so sound therapy can be with hearing aids. Just amplification itself may be enough. And I always say, I was just talking to someone today that was asking me about tinnitus, and I said, and a colleague, and I said, don't put all your cards on the table at once. So don't jump in with a patient and immediately start with a hearing aid, with a sound masker, and give them apps to use, et cetera, et cetera. Then if 2 months, 3 months, 6 months later, the tinnitus gets worse or something happens, you have no more options to work with, okay? So they have to be patient. They need to know that it may take time to find the right option for them, but I would say start one by one. So again, this goes into counseling. The patient has to understand is what worked for my patient yesterday might not work for 10 other patients. And what works for you might not work for anybody else. And that's part of your education and counseling. If they understand that, then they will understand why one thing is not working and why we're trying different options. So when it comes to sound therapy, yes, amplification is an option itself. Just if they have a significant enough hearing loss, then you can give them a hearing aid. The amplification itself will make a big difference, and we've seen it before. They'll say that is enough. That, to me, just that amplification made a big difference. It may be a potential option for Mr. B because he does have a mild loss at 4 and above, which is usually not the best. You usually don't get great outcomes for hearing aids for amplification purposes. And he's not concerned about his hearing, but if he's open to it, he might notice a difference. So it's worth trying. And again, it doesn't hurt to try. So keep that in mind. Sound therapy can show up as using external devices or sounds. So you're either using speakers at home, the TV, the radio, audiobooks that people can listen to, or just environmental sounds. So having, whatever in the background, ocean noise or whatever it is, working in the background, or soft music. For some people, that is enough. And what you're trying to do with sound therapy is you're trying to, and it's explained in the guideline, you're trying to lessen that contrast. Okay, so the patient is sitting in quiet and all they hear is tinnitus. So it's just all they're thinking about, and it's just bothering them all the time. But if you add to it environmental sounds, so the ocean, some waves, now there's more than one thing going on. And the focus is now, and the concentration is not just on the tinnitus. That is the kind of theory and the idea behind the sound therapy. So keep that in mind. And I am going to say, make sure when you're doing it, then applying the sound therapy, that we do it correctly. And that means I don't sit here and my tinnitus is at a level of 3. So then I'm going to put my environmental sounds at a level 7 so that it's extremely loud and I don't hear my tinnitus anymore. That is a big no. Okay. So the reason why I'm saying it's a big no is because if you are giving them sound that is higher than their tinnitus and they don't hear it anymore, and now they're going to go to sleep and they're going to turn off the TV, what's going to happen? Their tinnitus now is back, and instead of them saying it's a 7, it's now a 10. And that's not what we're trying to do. It's never, we know if we say it's persistent, for the most part, it's not going to go away. The idea is to shift the focus so that it's not 100% on the tinnitus, but now it's 60% on, or whatever, how many sounds you're using. So 60% on tinnitus, 40% on the environmental sound, or 60-30, and then 10% if I'm watching TV, or, so the idea is that they should, please keep this in mind, they should still hear their tinnitus. The idea is you have to reach what they call the mixing point, where the sound of their tinnitus with the whatever sound they're using, they kind of mix together. All right. So they can distinguish both, not one is louder than the other. Okay. So that's really important. Another option is using apps. So I just put 5 apps from the 5 different hearing aid companies that we mostly work with. There are other things that, like, you just put YouTube and you put Zen sound or sound therapy. You'll find a lot of different sounds that you can ask the patient to listen to. And like I said, it really is going to depend on your patient. They might like ocean sounds and some of them might hate it. And you'll see that. Somebody's going to tell you, oh my God, I feel like my tinnitus now is times 10 because there's other sound and I hate it. And again, your counseling is really going to come a long way if they understand it's really a trial and error. You have to go home now. I'm going to give you all these options. Go try to find if it's environmental sounds. Is it just, just music? Is it the radio in the background? Whatever. If that's what works for you, great, use it, done. Okay, so they have to play around with that and figure it out. The apps are really good because if they eventually have hearing aids, then they can stream them, stream the sound from the apps into their hearing aids or their Bluetooth iPods or whatever they are, or AirPods. So you want to give them those options, and then they can try to figure out how to, show them. They have to sit at home in a real life situation and try to work it out. Like, for example, and I'm just giving this as example because I've used the tinnitus, the relief one for resound, but you can actually mix the sounds that you want together. So I can say, I love ocean sounds, but I also like, I don't know, the sound of birds chirping at the same time. And you can add that, and they can make it their favorite, and they can save them and use different mixes of sound at different times of the day, which is even better because now you have more options to work with, so they don't get used to it. Because the whole idea is that you're having more than one thing going on, is that your brain is not now is not focused on one thing. It's focusing on more than one thing. The sound is changing, like ocean waves, it's high, low, etc. So they have more options to work with. So keep that in mind. Benefits, quality of life, anxiety, depression, just sound therapy in general, we know is helpful. If people just like to sit down and listen to music, it calms you. And why is this important? Why is being calm important? I'll get to it when I come to cognitive therapy. And I know that there's a question in there that I see about cognitive, and I'll get to it. But yeah, there's so many options when it comes to that. Some of these apps are actually timed. So if they have trouble going to sleep, they can turn on the app and say, I want it to, like, this sound to work for 2 hours. By then I'll probably be asleep. So now the app is going to turn off. So you have so many options when it comes to the apps now. All right, so now when we go into cognitive behavioral therapy, you'll find that in table 13, it actually describes it a little bit. But for the most part, anytime you Google cognitive behavioral therapy, you're going to see something that looks like this on the top right-hand corner. Thoughts, emotions, behaviors, and physical sensation. It's a cycle, all right? So let's say I have tinnitus, and in my head, I'm like, oh my God, this is bothering me. It's never gonna stop. It's gonna keep getting worse. So now my emotion is I'm getting angry and I'm getting frustrated. And now it's gonna show up in my behavior. Now I'm gonna be mean to people. I'm not gonna be a very nice person, or I'm gonna be isolated. I'm gonna be depressed. And now I'm sick to my stomach, right? And now I'm just not, so it can show in behavior physically, like you can be aggressive, and we can see that sometimes. So it's a cycle. And cognitive behavioral therapy was initially used for treatment of anxiety and depression, and it could be done individually or in groups, but a lot of research has been done on using CBT for tinnitus. And because anxiety and depression are some of the emotions and the behaviors that are going to show up because of tinnitus, so you're targeting the same thing. It's all cognitive issues, okay? And when the question I can see is, who do I refer to for cognitive therapy? The question, so cognitive behavioral therapy, you need somebody that is, usually psychologists do it. If they have the training, they should be the ones that, because they work with it, like I said, for anxiety, for depression. It's a matter now of applying it to tinnitus. But this psychologist has to have the background in tinnitus and understand it to apply it to a specific patient. I actually don't know if we have anybody that has that focus here in Saudi Arabia, but when it comes to group therapy, another way of thinking about it, if you decide to have your own work with your own program, or to establish something. When I did group therapy when I was in the States, what we did was, it was 4 sessions. So every week there was 1 session. 2 sessions were done by an audiologist, so it was either me or somebody else, and then the other 2 was actually a neuropsychologist. And her focus was tinnitus because her husband had tinnitus and it just got her interested. So she would discuss the whole cognitive part of it and explain how this is something that we know happens either with tinnitus or any other issue, anxiety or whatever. And this is how we're going to work with it. And just like, remember I was telling you, education, just understanding it, and having a name for it, and knowing that this is a cycle, this is what I need to break. So the goal of CBT is breaking that cycle. They have to stop this from going on and on and on in a circle, okay? And that's our goal here. We're trying to make the patient habituated, right, to the sound, because we're not going to say we're going to, remove it. We know it's persistent. Until now, there's nothing that we know of that can purely just take it away. But the idea is to break that cycle, the emotion, the behavior. They have to now think more positive thoughts, etc. And it's documented. It does great for a lot of patients. When it comes to, I was going to say for cognitive, I lost my thought on that, but yeah, the idea is to break the cycle. And yes, it's usually clinical psychologists that are trained for CBT. If they deal with anxiety and depression, they should be able to do the same, but they need the background in tinnitus to understand how it works. So audiologists, usually what we did, we talked about the theories behind what we think the causes are, et cetera, questionnaires, et cetera. We talk about all the apps, the options that they have, sound therapy, and then the psychologist then talks about all the other stuff, behaviors, emotions, and how just breathing exercises are known to alleviate anxiety. And if your anxiety level goes down, so does your emotions, those negative emotions go down. So you're almost trying to break the cycle somewhere around here, right? Between thoughts, emotions, and behaviors. Breathing exercises, some of the apps actually have those breathing exercises because they're known, tinnitus or not tinnitus, they are known to be beneficial in general. Relaxing is a big one. So you'll see those in the apps as well. And some of it, I know at least for the resound relief one, it does have breathing exercises. So it's something that patient can do eventually. Once they finish their therapy, they can eventually move forward and start doing things on their own once they understand the concept. When it comes to hearing aid evaluation, so now that we talked about Mr. B, these are the most, for the most part, these are all the things that are probably going to apply to him. And then what I was telling you about hearing aid evaluation, like I said, with hearing loss, typically that's when you're going to use it. But there's no harm in trying. Even if a patient says, like I said with Mr. B, even if he said, I'm not concerned, I mean, it doesn't hurt to try. Amplification alone might be enough. And then remember I was telling you, don't put all your cards on the table at once. So just try amplification alone, see how the patient, what they think about it. And then maybe if it doesn't work in the hearing aid, you're gonna add a masker, and it could be noise or other sounds. And this is where it's important which hearing aid you decide to give the patient. Some hearing aid companies don't have, only have noise. So either white noise, pink noise, etc. Where other companies actually have ocean noise and different types of ocean noise, for example. So if that's something that the patient really wants to try, then if if they try just noise and it's enough, then they can go one way or the other with a hearing aid, right? Also make sure you consider what type of hearing aid they have. What type of phone they have, so that you can decide which hearing aid. Because we know that some hearing aids are made for iPhone, or they are compatible with Androids, etc. Because then they can stream all the sounds that they want. They can make the changes easily through their phone. They can use the app and stream the sounds from the app to their hearing aid as their option if they're not actually using a program that has a masker. They just turn it on through their phone as needed. Or you can have a separate program. So in the hearing aid, program 1 is the same as 2. The only difference is one of them has the masker and one of them does not. So the patient can maybe, remember I was telling you, use a scale for patients, a number scale. So how bad is your tinnitus? So if they're having a bad day, then they might want to use it, and other days they might not want to use it. Oh, and Okay, and then one important thing I was going to mention about using the scales here, when I was saying, you know, do you have good days and bad days? And I noticed this when I was doing group therapy once. The first thing we did when we first started, I asked everybody on a scale of 1 to 10, right now, what number do you give your tinnitus? 1 being it doesn't really matter, 10 means extremely bothersome and I cannot handle it. And just for the 2-3 seconds, if they just sit there and they're like, I think it's a 6. And I'm like, okay, so that means you have to think about it. That means you probably have good days and bad days. So we need to remember that. You know, it's not always going to be bad, and that's enough to give patients motivation. If you're thinking about it, that means, okay, today is a bad day. It's probably an 8 or 9, but you know, I do have good days. Another thing I didn't mention here was, yeah, so the same goes with, you know, yes, you're going to tell them that there's no cure, but they have to understand that that's important to tell them because they have to have realistic expectations. But if you compare it to hypertension, for example, is there a cure for hypertension? Not that I know of. I know that people take medication to keep it leveled or whatever, but there's no cure. So it's the same concept. Tinnitus, as of now, there is no cure. You just need to learn these therapies, or you know, sound therapy or whatever exercises that you're going to do to help you deal with it, right? So always give an example that's very familiar. That goes a long way as well in your education and counseling. I always use hypertension as an example. So with a hearing aid, like I said, you can try different options and don't try all of them at once. And benefits also can be instant. I mean, you can see a patient's eyes just light up just by adding a very soft masker, and they'll say, wow, it's a big difference. That doesn't mean it's not going to change maybe a year from now, but you can see it instantly sometimes. If you are going to go ahead with hearing aids, please consider using open fit hearing aids versus an ear mold or in the ear hearing aid. Because why, any thoughts of why? Think about it for a second. I'm going to give you the answer, but just think about it. Why would I consider an open fit hearing aid versus a hearing aid with an ear mold or ITE? Because remember when we were talking about sound therapy, we want other sounds to come in. We want them to hear the normal environmental sounds. So if they just have a very mild high frequency loss, definitely go with an open fit receiver in the canal. Or if they have a more significant loss, maybe use an ear mold. But if you can get a vent in there as large as you can without causing feedback, go for it, because it is better. If you just close your, you know, if you just put your hands on your ears and you just block your ears, you can hear yourself louder. So some people perceive their tinnitus louder by doing that. So that is definitely something to consider if you decide to go to hearing aids. So when we go to against or no recommendation, and again, because it's against or no recommendation, I'm not going to go into too much detail, but it's, the idea is there, right? Is that medical therapy, and when we talk about medical therapy, is when we're talking about medications, like some people get antidepressants or whatever. No, the recommendation is against if the patient, unless the patient actually does have anxiety or whatever. Yes, absolutely, but that should not be your first. That should not be your first recommendation at all, right? Dietary supplements, some people are going to tell you, oh, I found zinc or ginkgo biloba, whatever. There's a lot of people that you're going to find. If you just Google tinnitus treatment online or medicine, you'll find a lot of stuff. But we know for a fact that there's no research right now saying that that it is beneficial. Because if you think it's really what these supplements are doing is it's what they're made of. Some of them are just, you know, kind of like things that make you relax, etc. And that's what we're doing with cognitive behavioral therapy. You're actually making people relax and calm down, and that's what makes it better. But again, if you look into detail about dietary supplements, some of them have had side effects depending on the patient's situation. So keep that in mind. It's not the best option. It's actually a recommendation is against. Acupuncture, there is no recommendation right now, and the only reason there is no recommendation, and you'll see it also in the guideline, when they're saying no recommendation versus strong or just recommendation, it's just a lot of it is dependent on how much research is available, how much evidence we have. For acupuncture, there's not a lot, so there's really no recommendation for them to say do it or don't do it, recommend it or don't recommend it. But the reason why I'm mentioning it though here is because, first of all, it's there in the guideline, but also patients are going to come and tell you, oh, I heard about this and this and this. You have to be knowledgeable enough to know that, you know what, I've heard that, you know, some studies showed a change and some have not, but there's nothing 100% sure yet. There's no true recommendation on it. Transcranial magnetic stimulation, again, it's not something that we've found great research on. But you need to know this information, although it's against whatever, but stay up to date, because this was 2014. Maybe the new guideline a year from now is going to say, yes, we have found a lot of studies that say acupuncture is great. So these things might change. Keep that in mind, that what we're saying right now might not be applicable next year. And then my last note is keep these things in mind. Like I said, do not use all your options at once. If you're using sound therapy and maskers, please do not let them be louder than the tinnitus. Like we said, we have to find that mixing point. Use questionnaires and scales. It's great for motivation, not only for the patient, but also for you, because it gets frustrating too when you're trying to, you know, help a patient and you don't see any change. But mostly for sure for the patients, it's great motivation for them, but it's also, I should have wrote this too, but it's also, like I said, depending on what type of questionnaire you use, it will show you that, oh, their main focus is like sleep or whatever, their social life, etc. Those are the things that you're going to focus on then when you talk to them and counsel them. And like I said, stay up to date, because what I'm saying to you right now might not be the same in a few months from now or a year. We don't know. So, especially with tinnitus, there's a lot of unknown. So there's always going to be research coming up. So keep yourself updated. Even if it's not, there is no recommendation or they recommend against, you should be aware, so that if the patient does ask you, you have something to back you up and you say, you know what, we know for a fact that it's not beneficial, or blah, 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 right? So keep those things in mind. And that is it. I hope that kind of gives you some type of template framework of what to do when you have a patient with tinnitus. If you have any questions, I am more than happy to answer them.